much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host, Jessilin Quint. Hello, Jessilin.
Hello, Jackie, and hello to all of our listeners.
Jessilin, I have to tell you something. I don't know if you're told that you're doing a good job or not, but let me tell you something. I did a lecture in Chicago recently, and I ran into one of your old classmates. And this classmate said, Jessilin is incredible. I told her when she was a student that she's going to like run everything, run all of optometry, and she's like killing it. And I was like, yeah, I know. She is so incredible. So, you're doing a great job, Jessilin. Shout out to Patrick Walsh, your old classmate.
Oh
Okay.
my goodness. Hey, Patrick, we love you. And thank you so much for just, the ego boost, the kind words.
Yes.
No, but you know who else is killing it?
I know.
Everything is our guest today. I think we should call this episode like the Blink Games, and we need like a soundtrack with it. But
Ooh,
I think
yeah.
the Blink Games, because
Yes.
this guy is at the top of his game.
I know. The more guests we have, the more I'm like, I don't do what am I doing with my life? Like, this guy is doing great. And actually, you guys the listeners probably already know who this is because it says it in the title usually, but I bet people could guess who he is by his voice. Don't you think? You guys, Cory Lappin is with us today. Don't you think you have a distinctive voice, Cory?
I don't know. I'll ask you. I hear myself recording, and I don't know if it's distinct anymore. I listen to myself all the time, so I just tune myself out. So
No, it's a great voice. I think people could know you by your voice for sure. But anyway, we're so happy that you're here, Cory. We're going to talk tonight about eyelid laxity. For all of our listeners, they probably know you because you're so well recognized in this ocular surface disease space. But let me do a little more formal introduction for those who may not know you. Cory focuses exclusively on the treatment of dry eye and ocular surface disease. He's authored numerous articles, given so many lectures on these topics. He's currently, this is super exciting, and actually we should probably pick your brain on this, but he's opening the Dry Eye Center of Ohio. So a dedicated dry eye and ocular surface disease practice in Cincinnati. He's a fellow of the American Academy of Optometry. He's a member of the American Optometric Association and the Ohio Optometric Association. Do they say OOA? Is that what they say? That's kind of cool. Okay. He's previously served as secretary on the board of directors for the Arizona Optometric Association. He's the chief medical editor for the e-journal Optometric Physician. I'm sure you all have read that. And he's a member of the editorial board for the online eye care publication Eyes on Eye Care. He receives awards. Of course he does, because he's Cory Lappin, but he's received the American Academy of Optometry Foundation Practice Excellence Award and was named the 2023 Young Optometrist of the Year by the Arizona Optometric Association. He's also a graduate of the AOA Leadership Institute 1.0 and 2.0 programs. Cory, thank you so much for being here. We're so happy to have you.
thank you guys. I'm super excited when you asked me about this. I mean, honestly, more than anything, it sounds like it's going to be a lot of fun.
Yes, it is fun. We're fun, right, Jessilin?
Of course. No, it's really good. And I'm excited. Every guest we have, I always learn so much from, but you come with just a wealth of knowledge and experience. And for being as young as you are, I mean, the mountains that you've already climbed is just phenomenal. But, our podcast is called To The Point, so I want to get to it. But I have a question. So, there's so much in dry eye, and lately a lot of your lectures have dealt with different blink dynamics and how we know, the eyelids and the laxity and all of that can impact the ocular surface. So what are you seeing in your clinics? Talk us through some of this eyelid laxity. How do you characterize it? What sort of impact do you see?
Yeah, eyelid laxity is an amazing thing because it's kind of something we'll discuss, but it was always kind of on the periphery. You know what I mean? We would dive into, oh, well, this patient has aqueous deficient dry, this person has evaporative, and that, all these tidy buckets that we know don't really exist. It's this giant continuum. And we looked at all these factors, and yet, probably one of the most central ones in modern dry eye is blinking mechanics, is lid positioning, because this was something that started obviously when I was working with my mentor, Dr. Art Epstein. He talked about blinking mechanics from the very beginning. And our whole ocular surface system is this beautifully intricate system that's all tied. And blinking is foundational to that. When we blink, that's how we renew our tears. That's how we secrete our tears. It seems, like it's going to be common knowledge, but clinically, how often do we actually think about that? We dive into everything else, but how often do we sit back and actually look, how's my patient blinking? Where is that lid positioning? Am I really sitting down and looking at that just as closely as I'm looking at a staining pattern on the surface? So, really, now I think focusing on the blink as a grander, part of this whole intricate system is going to lead us to a lot of unique therapeutic options going forward.
One question, but so for people listening who are like, how do I really assess lid laxity and blink patterns? What are your tips on how you even look at that when you're assessing a patient?
There's a lot of ways. So for me personally, if you have this setup, it's great when you have diagnostic technology, because I use some of like ocular surface analyzers, things like that. Like I use the BOSA, and that actually gives me blinks. It gives me full blinks, partial blinks. That's great. But at the same time, not everyone has that, and you don't even necessarily need to do that. All you have to do, first of all, look at blink patterns, is put them behind the slit lamp and watch. You don't even have to tell them, because once you tell them, the psychological games start going. Just watch. Tell them, hey, you blink normally. See, are they blinking frequently? Does it look like their eyes are irritated? Are they just kind of staring? And then the biggest thing is watch for closure. We so often, it's funny, I feel like everyone talks about blink rate, right? Oh, you're not blinking enough. You're blinking too much, especially when you look at that. Blink rate is important. But when you look at the literature, it's complete closure that's mostly associated with dry eye, more so incomplete closure. So that's what I want to see is, if I watch a patient blink 5 times, how many times are those lids coming together? Because the whole system is predicated on that complete lid closure. When we talk about this, we go back to the anatomy. When you think of the lids, we talk about the lids, but do we really think of the fact that mainly it's muscle in there? Like, that's, to me, I didn't think about that much, but it's the orbicularis oculi muscle and the muscle areola, and big muscles right there. You got the levator in the upper lid, and that's supposed to basically contract and close the eye. So if it's not closing all the way, now you're thinking, is this even muscle weakness? We so often talk about lid laxity from a skin perspective, as we age is one thing, but we also lose muscle tone as we age. We don't blink as forcefully. And then the muscle position. Again, I always think back to the anatomy. You have the tarsal plate within the lid, and within that, you have the meibomian glands. But when you blink, the orbicularis contracts and it presses on that tarsal plate, and it pushes the meibum outward. And right at the terminal end of the duct, you have the muscle areola, and that small muscle, which basically holds the lid close to the globe. It actually goes between the ductals and the acini, and it kind of pushes it out fully at the end. But if you have lid position issues, lid laxity, you're not contracting as forcefully, you're not going to be getting that meibum secretion, and then you get all the downstream problems we see in MGD. And again, that just goes back to lid positioning, lid laxity, and basically blinking mechanics.
I like that you brought up the muscle, and I've heard you use this analogy, kind of comparing it to when we train our muscles for the rest of our body in the gym, right? And the impact that that can have. And there is, and of course, as we've had new dry eye innovations, the fact of being able to apply that analogy to maybe something on the eyelid, because of the innovations that we've had, that makes a little bit more sense. So, there's like Optilift, right, is out right now that is really kind of aimed at strengthening possibly that muscle component to some extent. Can you tell us a little bit more just about the treatment or how that applies, or how we can really kind of tease out, is this more of lid positioning, how much of it is muscle based versus some other mechanism that's happening?
Yeah, so that's the interesting thing, is really, you kind of look what we had before, we didn't have much. It's kind of an out of sight, out of mind thing. So often we've seen this with other conditions, whether it be neurotrophic keratitis, Demodex blepharitis. If you didn't have a treatment for it, did you really look for it? No. But now both of those things have treatments. And guess what? We're seeing both all the time. And I think it's very much that case for lid laxity right now. Because before, I'll tell you what I recommended was blink exercises. And there are some studies that show it might be helpful, but the problem is compliance is terrible. And it's not because patients want to be non compliant, it's you just forget, right? It's hard to tell yourself to do something you're supposed to do subconsciously. So now with something like OptiLift, we have something that actually targets the muscle. And you have a really good kind of, question there. How can you tell if it's positioning from like perhaps just even the lid, the skin naturally kind of losing some of its rigidity versus the muscle. And I think what we're kind of seeing now is it's a combination of both. I think a lot of times we see both. Naturally, we're going to see it more with age. Obviously, we get that reduction in muscle tone, and that starts in our 30s. As much as people hate to hear it, we start losing muscle mass in our 30s. So, of course, our older patients, those who are in their 60s, 70s, but it's going to start early. And even now, sun exposure, other things like that, it's going to degrade our collagen. We're going to lose elasticity. So, likely, it's probably going to be a mix. So, I wouldn't ever be overly worried about saying, "Oh, is this purely muscle? Is this purely, more mechanical changes to the lid skin?" Because it's probably a bit of both.
One thing I think you mentioned putting the patient behind the slit lamp is a great way to just to assess blink dynamics. But there is also this, snap back test where you kind of touch this lower lid and pull down and just see how quickly does that lid actually snap back up against the globe. And I think this is an easy thing to incorporate in your exam. I do this when I'm putting in fluorescein, like I pull down the lower lid for the fluorescein strip. But I think even that is an opportunity just to look at how quickly that lid kind of snaps back to that globe. And that tells you how much laxity we have there. And so, there tends to be, I mean, you could touch on some of this, but a certain patient that we might see that more, or a patient that might be a little bit of a higher risk for the eyelid laxity. Are there any patient, demographics or telltale signs that clinicians should sort of look for when they see it? And are there other workups that are needed when you start seeing some of this like lid laxity and floppy eyelids?
100%. Whenever I do a dry eye or more broadly an ocular surface exam, I like to say, well, I work my way outside in, and it starts with the lids. And what you just mentioned right there, mechanically manipulating the lids is so important. And I also like that you said you're putting in fluorescein, right? It's not something you're already doing these things. That's what's wild to me. We're already doing these things. We're just not thinking about the fact that we're doing them. And so the snapback test, like you mentioned, is great. That lower lid, when you pull it down, it should only take 1 second or less to go back. If it doesn't, you have some laxity. I really like, if you guys have kind of heard the whole look, lift, pull, push kind of one. Guess what? We're all doing that anyway, or at least, likely should be doing that. So it's a really quick way to assess that. When you lift up on that upper lid, it should give you some resistance, right? It's not supposed to come all the way off. You're not supposed to easily do that. So I think that mechanical manipulation is good. The biggest one that I'm so shocked that I think it's overlooked all the time is inferior scleral shell. I all the time say we have natural lid positioning. The upper lid should be about 1 to 2 millimeters, below the superior limbus, and the lower lid should be at or slightly above that lower limbus. And if you see any sclera between the iris and that lower lid, you have an issue. We should not see that. So that right there is a big one to me. Like if you look, and you're going to see that all the time, and you can get exposure issues, all kinds of things. And then alongside that, you also get things like nocturnal exposure. I always bring up the difference between traditional lag ophthalmos and the poor lid seal, because a lot of times they're interchangeable, but they're technically different things. Traditional lag ophthalmos is easy to see. I always have my patient tilt their head back, close their eyes, use the transilluminator. If I see any sliver of, anything peeking out, we know it's lag ophthalmos. But a poor lid seal is more like an overbite. The upper lid will gently drape over the top. They are touching, but it's not that tight seal. But they'll have all the same symptoms of someone with lag ophthalmos, and that's where I don't know if you guys like to do this, but I like to use the core Blackie light test for that. You just take the transilluminator, put it on the upper lid, and if you see the rays of light kind of shining out, you can see it. Or you can simply ask them, how do your eyes feel when you wake up in the morning? Is it worse? Because that's a pretty one-to-one symptom to an actual condition that I've noticed as well.
Absolutely. I love that classic telltale sign of, when are your symptoms worse in the morning for sure. I think just especially bringing more awareness to the eyelids and those blink dynamics, I think long-term wise will allow us to kind of detect some of these cases in a more earlier form, right? Because eyelid laxity, like I know we all probably immediately go to like floppy eyelid syndrome, right? Like kind of, the end stage, we're well packed. So we might be at the point that surgery is kind of possibly only the real option for kind of a long-term management plan. But being able to just catch some of these cases a little bit earlier on, I think is just going to kind of change our outlook of how we manage ocular surface and how we just can't forget about that component. And I think it's a reminder too that you can throw, all the topical drops or do some, speckling of different in-office treatments. But if you're forgetting about the eyelids, a lot of times your patients are still going to have some symptoms or clinical signs are going to see, keeps popping up. And so it's one of those important things that we just definitely cannot overlook.
I mean, absolutely. I mean, we talk about this all the time. You want to get to the root cause of things, right? Like, and and just seeing how often it's that lid laxity. I mean, I think I've talked with you guys both before. It's this comes down to even like evolutionary history. We don't use our eyes the same way that we they were developed. I mean, if you look back in human history, our ancestors were hunter gatherers, where 95% of their visual world was off in the distance. They were looking for predators and prey. They might look at something up close, like berries on the bush or tracks, and they'll look at it for like 20 seconds, right? They're not going to be like scrutinizing something so long. The problem is now our world's completely flipped. 90% of our visual world is within arm's distance. So, it's one thing basically to stare at, like, again, berries on the bush for a minute or so, your eyes are fine. But when you're staring at a screen for 8 hours and on end, and now we know the average is 11 hours of screen time. So that's fundamentally different. I mean, it's just not how our bodies evolved. So we're basically forcing our visual system to work in a way that's counter to exactly how it's been. And that's tough. And that's also what impacts our blinking. We want to blink, but we don't want to obstruct our vision when we're working on the computer or anything. So we end up doing those partial blinks I talked about. And not only are we having the aging changes now that's making us poor blinkers, but we're training ourselves actively not to blink, which is why now this might have been an issue we saw in older patients, but we're seeing it in younger patients. I mean, basically anyone who's of screen age, which I think is now probably about 1 year old and up, is probably going to be starting to have issues with blinking.
Yeah, okay, so this is a big thing that I see in my practice is I'll put someone behind the slit lamp and I will see all this inferior staining and then I'll just watch them blink and they really will not blink fully. And so that's why we're having all of this inferior staining is we have this incomplete blink. This is tough to treat. Like, do you guys I mean, there's certainly, I think, in more well, at any stage, a scleral lens could certainly help this patient. But what else are we doing? I'm saying, take breaks and blink your eyes, which is like kind of ridiculous, but like that's a great, thing to say. Or I have found perfluorohexyloctane can be helpful in this situation as well. But do you guys have other things? I think we could make a lot of money if we figured out how to fix the incomplete blinkers. Do you guys have an idea? What do you do for these patients?
That was basically until recently. It was what you said. You encourage them to blink, or you put something to protect them because they're not blinking. And even then, surgery. Here's the thing about surgery: everyone automatically assumes, oh, just get a blepharoplasty. That doesn't change function. That is just a physical, mechanical reorientation of the anatomy. You have not improved contractile force of the lids. You've just repositioned it. That's the whole reason. I mean, you see it all the time. You guys both deal with a bunch of ocular surface disease. Have you ever really seen someone get a blepharoplasty and that's fully fixed everything? No, no, it might help if they have really bad exposure, if they have ectropion, entropion, something like that. But it hasn't fixed the foundational thing. And really, as Jessilin was saying earlier with OptiLift, I'm so excited about this because this is the first time I think we actually have a treatment that's addressing this functional issue of blinking, of lid laxity. Everything else was just a band-aid in some form, quite frankly, whether we're protecting the surface with a scleral, hitting with that perfluoroxyl octane just to try to protect the surface, or even surgery, which is just an advanced way to reposition the lid. So I think that's what's so exciting about this with the whole idea of dynamic muscle stimulation is we finally have something that can address this lid laxity from a functional perspective.
I also wonder how many of these incomplete blinkers also have incomplete lid seal, right? As you talked about this earlier, symptoms are worse in the morning. I wonder what the connection is between these two groups of people, and maybe they coexist together, these two problems. And I think there's so much value in then really getting that surface hydrated up well while they sleep so they start their day great because they're about to traumatize their cornea for not blinking all day.
There was a study that showed in one group of patients that was refractory dry eye patients, weren't responding to treatment. 60% of them had nocturnal lid closure issues. So I completely agree, Jackie. I think that's what we're dealing with. There's so much overlap with this. And that's basically what's going on, right? Their lids aren't closing and it's leading to all these other problems. And that's why, again, I think dry eye, I joke, it's almost like I think of the Little Rascals. It's like three kids in a trench coat pretending to be an adult, but this is dry as just like three different conditions plus in a trench coat pretending to be this one thing when really all these things can lead into it.
Yeah, so true. So let's talk about Optilift a little bit more. And granted, at the time we're recording this, it's still fairly new, right? So we probably don't have just like a ton of personal experience yet. But even just leaning on the science and just even kind of to the basics of, exactly what is Optilift. Like if our listeners weren't quite familiar, like it's an in-office treatment, Cory, I'll have you kind of walk us through that. But then if you had a patient, and if of course, this is another piece of equipment that comes at a pretty high, price point, and so there's things that we have to consider. But if somebody was out there thinking about getting this and they were starting to think about like what candidates would be best for this treatment, what are some things that you would look for like with your patients that would be like, this is something where I would consider Optilift for this patient demographic?
Yeah, so OptiLift is a very unique device because we've kind of entered into this the interventional dry realm. That's kind of the cool term now we all like to use with things like IPL radio frequency. So OptiLift is kind of adding a new dimension to this. So it's dynamic muscle stimulation. That's the technology, and basically what this does is this is going to apply a small electrical current, and what that does is it basically causes muscle contraction. That's how our muscles naturally contract, as small currents, basically. And this is just adding an external, basically, stimulus for the muscles to contract. And that's more or less what we're doing when we're exercising, right? We're like, think of a bicep curl. We're flexing our biceps, we're contracting the muscle. This is doing that same thing. It's applying that current, it's stimulating the muscle, so it's contracting. So over time, that's going to basically strengthen the muscle. So that's one element. It also does have some radio frequency that's involved too. It's a little bit different than what you would get with something like Opti Plus. That's a little bit beefier, is the way I would say it for this. But this one is giving you a little bit of that heat, which is good because that can help with some of the more of that collagen aspect, the degradation of elasticity from the skin. So you help with that a little bit. You're also getting some heat to the meibum. So if it's stagnant, it can kind of help, melt that a bit, which is great because now you're getting that kind of 1-2 punch. You're getting the contractile force from the dynamic muscle stimulation, and then you're kind of, melting the meibum, making it easier to pump out. So that's a great 1-2 punch. So that's really what you're getting with dynamic muscle stimulation for this. What patients you're looking at, I think this is where, kind of going back to what we talked about at the beginning, let's set some, certain tests we're going to do every time, whether it's that, lid distension test where you pull the lower lid, that snapback test. Find something that works in your clinical flow that will be at least one test of lid laxity. So a patient comes in with dry eye and you find they have a snapback test. The lids are just kind of sitting, they're not snapping back quickly. Or you can just pull on that lower lid and it just keeps pulling out like you're stretching like silly putty. Those type of things, if you see things like that and they have dry eye, okay, this is a patient who would probably benefit from OptiLift. So really for me, it's like just come up with something and add that puzzle, that puzzle piece in, and it becomes relatively straightforward at that point.
Yeah, I think it's great to actually get yourself an established protocol. This is anything, right? When you add something new to your clinic, the question I'm always like, who am I doing this to? How am I working this into my clinic? So it's great advice on how to work that into your clinic. And Cory, you're really in it because you're building your own clinic right now. So you probably have protocol after protocol, going on what you're doing with your patients. Any tips on that process for somebody who wants to maybe add some of this equipment in? How have you reasoned that out in your head?
Have a plan. You nailed it, Jackie. That's the thing, is because too often I joke kind of sadly, I've seen some very expensive paperweights in eye care. I go into practice and someone's like, they're like, yeah, that thing over in the corner collecting dust. I spent a lot of money on that. So when you get these devices, I'm a huge advocate for adding these advanced procedures, but you have to have a plan. You can't just get this and expect that it's going to do the work itself. As good as these devices are, I've yet to see one, go up to a patient and do all the work itself. So have these protocols, already know ahead of time. This is where I'm going to implement it. And here's the other thing. Don't be afraid to do it when it comes up. Because so often everyone has a plan and they're like, oh, this patient looks like a slam dunk. But then they kind of get cold feet because, like you said, there's cost involved. These are out of pocket procedures. Have a plan, educate the patient on what you saw, let them know, hey, this is why it makes sense, and then go for it. But that's the biggest thing. Come up with a protocol, one that works for your office, your exam flow, and just roll with it once you have that.
I love that. We're gonna have to do a part two probably for our blink protocol like a year from now. Well, now that this is even more front, on our radars, and we have a couple of new different treatment innovations, we're establishing those protocols, right? And we're figuring out, do we, what the recommendation was is and how frequently. And sometimes clinically it looks a little bit different than sometimes how it's always laid out in clinical trials. So we'll have to follow up when we have kind of a full year's worth of experience with this under our belt and see kind of where we're at. Well, Cory, this wouldn't be a to the point episode if we didn't ask you what your life lens is. So, what would be your life lens?
So mine's more of a philosophical one here, and it's a term that I use all the time, and friends and family probably get sick of me saying it, but it's so true, and it's basically taking physics but applying it to life, and it's the whole concept of an object in motion tends to stay in motion, an object at rest tends to stay at rest. I've found that has been so true for me that if there's something I want to do, I just need to do it right there, right then, and once I'm rolling, I just keep going until I'm done with what I need to do. Because the inverse is true. If I'm sitting there, there's something I'm not doing. Guess what? I'm probably gonna not. I'm gonna continue not to do that, and it's just easier to keep moving when you're working with something for that. So I think I remind myself that all the time. It's just and that can apply to anything in life that we want to do. It's just once you get going with something, keep heading in that direction, keep moving towards it, and just don't stop. Because once you do, it's just harder to stop up again. So more of a philosophical thing, but it's something that I tend to remind myself of whether I don't want to do something or anything like that. And I just found it's really helpful.
That's great. I love that one. And that's like so true for someone who's building out a practice, right? Like you just have to start. Just start, keep moving, make the mistakes, learn from them, but just don't stop. You don't actually strike me as a person who does ever stop, so I think that probably tracks for you.
I think that's my issue now is I probably should actually stop a bit more than I do is what I'm finding right now. So that's what I'm actually learning now is like, okay, how do you stop when you need to? Because eventually if you keep rolling, you'll find, the edge and there's that cliff and you're like, hey, you should probably stop before you get there. So that's where I need life advice. I need a like guru to tell me, hey, this is the appropriate time to stop.
I have no idea about that. So if you find that person, please let me know.
Definitely. Well, thank you so much for being here. I mean, always so wonderful to talk to you, and I always learn so much. For our listeners who maybe wanted to connect with you out of the To the Point podcast, how could they find you?
Easiest way I normally say just go on Instagram. That's the easiest thing nowadays. I feel like that's where most people are able to find me. It's just my name on Instagram. It's just Cory.Lappin. Nice and easy. Always reach out to me there. Again, if you've ever read Optometric Physician, email is on there. Just somehow you'll be able to find me or talk to someone who knows me, and somehow you'll probably be able to get to me.
Thanks so much, Cory, for taking the time this evening to talk to us. It's been great.
Yeah, thank you both. It was an absolute pleasure.